on this computer. Okay, so hi everyone. So we'll talk a bit today about the controversy around the PDA. As you know, we are locally a center that I don't like to use the word treat because treat implies that there's a disease that you need to act upon with a particular treatment that is shown to be effective. I use the word try to accelerate closure of the duct, and I think that will be more appropriate semantic, but in any ways, that's just terminology. And I think there's a lot of controversy, as you know, in the literature right now in terms of what to do with these preemies who have ductus arteriosus and, um, you know, a lot of controversy regarding the literature and a lot of confusion and a lot of erratic kind of, protocol are being dismantled or changed based on new studies coming out. And so we'll try to kind of dig through why is that. So I have nothing to disclose. And I think my goal here is to raise some questions about maybe some beliefs we grow with as practitioners and neonatologists. And at least I'll share my approach and how I see it currently. Perfect. So I'll start with the case. You're a 24-weeker, day of life 5, increasing oxygen needs, there's low diastolic blood pressure, bounding pulses, and a TNE is requested to rule out pulmonary hypertension or other hemodynamics contributor, wink, wink. You can see that this is the lung of the patient. So obviously lungs typically that are nicely aerated and without disease are very black with good air expansion. And in here, we can see that we barely see the heart. We see like kind of the bronchus a bit behind because it's filled a bit of air, but really it's kind of a complete whiteout. And whiteout tells you that the lung is very dense. So either it's dense because it's filled with fluid, or it's collapsed, or it's inflamed, or it's filled of some kind of alveolar transudate or things like that. And so in this particular patient, we see a lot of fluffiness. It's extremely well aerated. We see even that, the diaphragm is a bit flat. So probably we're trying to push even more mean airway pressure in these patients. So there's a lot of lung disease. When it comes to prematurity, these patients develop a lot of inflammation. And just being exposed to oxygen at a time of critical development puts you at risk of inflammatory changes, right? Like you take a being that is super immature, that is not supposed to be outside the womb, and suddenly you expose to the environment, which is a very big aggression for them when their lungs, heart, body is not ready for that. And then you expose them on top to interventions that is going to create even more burden of inflammation. So think about mechanical ventilation, stretching, breakage of alveoli, all these kind of disease processes. It's going to create cascades of inflammatory reactions. And being exposed to reactive oxygen species will also create a lot of inflammatory storm in these patients. And that's not even taking into account that many of these babies are born already with a reason to be in a very high inflammatory surge. So think about choreo, think about preeclampsia and severe UGR, think about preterm labor, rupture of membranes, colonization with bacteria and adverse flora effects. So all these things are like cumulative elements that are enhancing the inflammatory response in these patients. So you do your TNE, and what you see here, you see pulmonary artery, descending aorta, you see kind of the flow in the descending aorta, you see the flow in the left pulmonary artery, and you see this red flash at a relatively high Nyquist, which tells you there is flow coming from the aorta going towards the probe because it's red and arriving in the pulmonary artery. And you see it gets brighter yellow during systole and becomes more red in diastole, probably because there's peaks of velocities that are happening during the upstrokes of contraction. And if we put a pulse wave Doppler through the PDA, we'll see that the profile of this PDA, you see the two lines here, this is pulse wave Doppler, so it's obtaining the velocity of flow at exactly this point of interrogation. And it tells you there's a systolic upstroke. So QRS happened here. You get a peak in systole during contraction. Eventually, you get a diastolic fall of these velocity. So this tube has absolutely no point of constriction. So it's not creating any buildup of pressure within the tubular structure, because otherwise, if you would have a significant point of constriction and it would become restrictive, it means that pressure would build up within the wall of this tunnel and would continue to spurt blood flow at high velocity throughout the cardiac cycle, especially in a context of low PVR and high SVR. In this particular patient, you get almost zero velocity in diastole, which tells you the speed on both sides is like just equalizing. So that's why it has this pulsatile pattern, and in general, very low velocity, because the pressure on both sides will equalize, in the sense that if you would measure the pressure in the aorta and you would measure the pressure in the pulmonary artery, they're probably very similar at that point, because you have a big structure that connects the two and it doesn't temper any pressure transmission. So you get a lot of pressure transmission, and this is through flow, right? Because probably if you're equalizing pressure on both sides and the resistance is very low on the pulmonary end and SVR is higher on the other end, well, what's gonna drive this pressure equalization is a flow increase. So your pulmonary vessels are being exposed to increase flow and to increase pressure, basically, because the pulmonary vascular bed is not supposed to sense systemic pressure during this critical period of development. At least we know during fetal life you have big ducts, so the pressure in the lung and the pressure in the systemic compartment are the same, but you have very low flow in the lungs because the PVR are very high. So that's one of the big difference in these preemies being born earlier and with very immature vascular bed. And so there's always been a concern that sending too much blood flow to the lungs would create a situation where suddenly you're going to have a lot of spillage in your alveoli. And because of the spillage in the alveoli, you go into pulmonary edema. And because you have pulmonary edema, you have the concern that this puts the patient at greater risk of VQ mismatch. And because you have VQ mismatch, then obviously the logical step would be that you need to increase your mechanical ventilation support in order to ventilate and oxygenate. And because you do that, there's the concern that you may injure more the lungs, and it creates this cascade where you're enhancing the risk of your lung disease, thought to be secondary to the duct. Now, if we look at other markers by echo of large ductuses that are left to right, there's obviously, as you go along a few days old in these patients and your pulmonary vascular resistance are dropping, you're progressively increasing your pulmonary blood flow at the expense of the systemic flow because you're a still effect. And so by increasing the pulmonary blood flow, you obviously have to fit all of this in the pulmonary vasculature, and eventually your pulmonary venous return increases. And this pulmonary venous return eventually comes back to the left atrium. And if your left atrium is not able to decompress anywhere, which typically would decompress via an interatrial shunt, the atrium at some point is like a balloon, right? There's a certain level of how much it can accommodate. And so you're going to start seeing pulmonary vein distension and high velocity through the pulmonary veins because they're still fixed structure, even if they're veins. And same thing, the atrium will start distending as well. So if you have a big ASD, the ASD is just going to pop off the left atrium. But if you have a tiny PFO like most of these babies have, you're going to start distending your LA. So one of the markers is LA distension. And so that's why we use M mode, which has been described by Norman Silverman, at least 30 years ago. We do what we call the left atrium here on aorta ratio. So if you put your line of interrogation in the middle, you would have here the aortic valve and you have here the left atrium under it. And values above 1.4 of the ratio between the left atrium and the aorta at M mode is an indicator that you start having left atrial distension, right? But it takes time for LA to become dilated. It's not going to happen on day 1 of life when the PVR is still high, right? It's going to take like 2, 3, 4, 5 days, sometimes a week, because you need more pulmonary blood flow. Same thing, as the LA gets distended, there's flow that's going to go into the LV, and eventually your LV starts becoming very dilated because it needs to accommodate a lot of blood flow that's recirculating through the lungs. And so you see that the diameter of the LV, your LV internal diameter, will start increasing in size. And eventually your mitral valve will become dilated. So you start seeing like mitral insufficiency. And one of the unsigned is having aortic valve insufficiency when the aortic valve starts increasing in size. So whenever you do a ratio, don't forget that you have a numerator and denominator. And so if you have an LA on aorta ratio that starts increasing, it's either that your LA is increasing in size, your aortic valve is decreasing in size, or a bit of both. So if you have a high LA to aorta ratio and there's no PDA or no other reason why this LA would be distended, think about aortic hypoplasia, right? Coarctation, bicuspid aortic valve, small aorta. They'll have very small aortas on M mode compared to the LA. So that's important to remember when you're doing these evaluations. So this is a subcostal view. This is the interatrial septum. You have the left atrium, the right atrium under it, a bit of the liver. And what I'm showing here is that you're putting your collar. This is a high Nyquist, which means you're filtering velocities that are below 90, which is a high velocity filter. And what you see is that you get a very restrictive PFO. Why? Because the LA is very overfilled. And if you put a pulse wave Doppler at your PFO, you can see that you have very high velocity. So 1.2, 1.4, 1.2 plus times 1.2 times 4 gives you something like 8 or 9 millimeters of mercury, even 10 millimeters of mercury. So it tells you that the LA pressure is higher than the RE pressure for about like 10 millimeters of mercury at the peak. So during systole, during the ventricular systole, mitral tricuspid valve are closed and the LA and RA are getting filled, right, with liquid, with blood from the pulmonary venous drainage and systemic venous drainage. But because the valves, the tricuspid mitral valve are closed, the pressure rises inside the atrium and eventually you get an atrial kick just before no, sorry, this is in ventricular systole. So you see the pressure that rises during ventricular systole. This is a 4-chamber. You can appreciate the LV looks very distended, LA distended, your pulmonary veins are distended. You see like the flow coming back of the pulmonary veins that's like continuously coming back because probably you have so much pulmonary blood flow. You have mitral insufficiency here because your mitral valve annulus is becoming more distended. And when you're increasing your LV preload, if you follow the Frank-Starling curve, as you're increasing preload of ventricle, what's going to happen to the output? You're going to increase. You're going to increase your output. So often in these patients, if you're doing a Doppler in their LVOT, they have higher velocities, bigger output calculation. So it's not unusual to see that these patients have like 300, 400 milliliters per kilo per minute of blood flow. The other thing you see often is that in anything that's, initially post-ductal, you're going to see retrograde flow. So you can see a steal effect during diastole because the PVR are so lower than the SVR. So this tells me PVR lower than SVR and flow unrestrictedly going back into the pulmonary circulation or being stolen somewhere. In this case, it's the PDA, but we already went through what could be causes of retrograde flow. There's things like AVMs of the brain, aortic insufficiency, ventricular aortic tunnel, truncus arteriosus. So anything that would cause diastolic steal would present like this as a retrograde flow. And this is in the suprasternal view. This is from the subcostal view. It's the same thing we see here, retrograde flow in the descending aorta. And then this is flow. So you see here the descending aorta with the spine, and you see here your celiac trunk. And what we see here is nice retrograde flow in the celiac trunk during diastole. And when it's such a profound steal effect, you may even steal from the circulation in the brain, which is, part pre, part post-ductal. Because you have two typical carotid arteries, one that's pre, one that's post-ductal, depending on your arch anatomy. And you can see that there's retrograde flow also in the brain. Pulmonary venous Doppler, because the veins are still fixed, they're very elastic structures, and they're able to accommodate flow to various degrees, and they're low resistance structure. But still, at some point when you're forcing Niagara Falls through a straw, you're going to start having much more velocities of this flow. And we can see that we get an S wave, D wave, S wave, D wave, S wave, D wave. This S wave might be biphasic or triphasic. So here it's kind of triphasic. This, we're losing the biphasic part of the S wave, so S wave, D wave. And you can see the D wave in diastole during opening of the mitral valve, that actually you get even more acceleration of flow. And you have even a bit of AR, which is regurgitation just before at the time of atrial contraction. So you see high D waves in these patients who have a lot of pulmonary blood flow. But in life, we always have to go with science and try to see what is science telling us. And, it's very easy to kind of fall into the beliefs and pray at particular churches based on what people are telling you and what you're trying to believe, because that's what the, convictions that we have. But that's me at the academic of science and trying to look at what really the science is telling us. Because it's one thing to have a duct, it's another thing, what are the best strategies to address it? If we really think there is issues with that duct, are we blindly following particular approaches without robust science behind it? And sometimes these approaches are not great. So for many years, we thought that bleeding patients would be a really good treatment for some of the infectious diseases that we had, like in the Middle Age. We used to bleed patients when they were infected with bubonic yeast. Nowadays, we know it's antibiotics, the right treatment, but what, you don't believe that the infection exists, you should bleed the patient, right? Sometimes what we think is the right treatment is actually not the right treatment. And that's what I'm going to try to convince you today, is that we need to rethink how we address these hemodynamic concerns for some of these categories of diseases like the duct, because sometimes the treatments that we have are potentially more toxic and not giving the effects that we really want to. So this particular patients have many echoes concerned regarding the physiological effect of the PDA. And obviously on an immature premature infant, we're always concerned to have these disturbances that the physiology is telling us, oh, it's going to cause problem. And so the question is, could this left or right duct that is sending pressure and high flow contribute in what we call the causal pathway to the adverse outcomes of prematurity? What's the causal? Means that PDA left to right is participating, it's causing part of these diseases that we see in the baby. And assuming the answer is yes to that, first of all, we need to ask ourselves, well, what are really these outcomes that we're trying to improve? What is exactly what we're trying to get at, right? Like in terms of the improvement, when we're looking at whatever strategy we have to close this duct, or at least to constrict it, even if we don't achieve closure, to restrict the amount of blood flow through it. And so I've outlined here all the potential, and there's probably more complications of an extreme preterm, let's say 24, 23 weeker. And so you can think, the baby gets intubated and gets surfactant. And then because you give surfactant, there might be a component of very big drop in PVR. So obviously you're changing a lot the dynamic of the patient because you're giving surfactant and it's changing the dynamic of the lungs. And then you wonder, well, because I'm rushing blood flow and these capillaries are all immature and suddenly they're seeing a rush very rapid of the blood flow, well, they're going to burst. So you get pulmonary hemorrhage. You could get, rapid shifts in the intestinal perfusion, and in an immature gut, it could create a perforation. Maybe these shifts are changing and causing IVH. Maybe because there's chronic underperfusion of the gut and diastole. Who knows? Are the babies able to auto-regulate despite that or not? Is it causing neck to have this? While we're doing all this, these babies are growing and their lungs are getting progressively damaged by all the interventions and all the inflammation and all the oxygen. So there's evolving lung disease. And then you start developing eye problems because of all the oxygen drops and ups and downs and ups and downs, and the growth issues because we're not able to nourish them. And then, oh, maybe it's going to cause pulmonary hypertension and white, matter damage. And then who knows, maybe because of all this, these baby die because you chose to reroute the care of a baby with severe IVH, or because they got a neck, or because they were not being fed, they have a PICC line and they get infected. And then because of all these complications, because part of it is the duct, the duration of hospitalization. But Really, it's, when you take the PDA, you could probably find a good reason to say, well, physiologically it makes sense that it's participating in all these concerns. But preemies, and especially the more you're born young, the more you will have a PDA because naturally these patients are not closing their duct because they don't have the mechanism. They're not programmed to close the duct. Evolution has made that this duct has to stay open in fetal life with various strategy to prevent its closure. Because we know that if you close your duct at 23 weeks in utero, it's really, really bad. So what are the things we have to keep the duct open? It's obviously prostaglandin. So the placenta is producing a lot of prostaglandin, but the tissue surrounding the duct, so the endothelium of the duct itself is a factory of prostaglandin. So the duct itself produces prostaglandin, and as the baby becomes older or the fetus becomes older, these endothelial cells are starting to stop producing prostaglandin, and that's why often our preemies that are a bit older, they close their duct because they reaches earlier maturity. And so they're able to close the duct. And so that's the first mechanism. And the second mechanism is obviously we know that oxygen is a constrictor, but to constrict, you need muscle around the duct. And so this muscle or these muscle layers will actually become more and more mature and more sensitive to oxygen and will develop to a higher degree during actual gestation. So at 23 weeks, you don't have that much muscle. And that's why you could constrict to some degree, but you typically have more difficulty closing it completely because you have less muscle. Now, often we'll see some of the IUGR babies, they have early closure of their duct. Why? Because they have vascular stiffness and the muscle around their vessels, just in general throughout the body, has a tendency to be a bit more developed because of their vascular stiffness and because of the fact that they were exposed to placental insufficiency and they have a tendency to have higher vascular tone through probably a mechanism of buildup of muscle around their vessels. So they tend to close some of these patients a bit earlier. So now that we have some of these outcomes, the question is, well, how much the PDA could be contributing to the causal effect to these diseases? We know all these diseases are very multifactorial. There's there's a component infection, immaturity of the gut, flora, the way you feed the baby, whether or not there's growth restriction or not, placental insufficiency or not, choreo or not. So all these things are contributive to many of these pathways of diseases. So that's one thing that is a bit of an issue. The other thing is, what about the timing? I think there's a lot of controversy, even if you want to try to address the duct. Well, if you're going to give medication or treatments to these babies on day one, they all have a duct. By day three, maybe 70% have a duct because some of them, you allow them to close it. And as you go along, less and less have ducts that are open just because they inherently have mechanism to close it. But for some of them, they do it earlier than others, especially if you're a bit more mature in terms of gestational age. And so timing is important because IVH doesn't happen like late. It happens very early, right? BPD, pulmonary hypertension, is something that takes time. It's like a burden of disease that is cumulative. So whatever strategy you're going to look at, well, timing is a concern into that. And so if timing varies at what time and how should we address this shunt? That's one of the questions that many people are asking. So we'll start with IVH. We know IVH has multiple contributors, prenatal, postnatal. Like if you're born outborn, you didn't have steroids, you get resuscitated by a team that's not used to resuscitate these babies, then obviously your risk of IVH is much higher than a 23-weeker being born at the MUHC with a team who's been doing that for like the past 40 years. Beta-metazone, controlled environment, controlled timing of delivery, MFM specialist, all these things will be add-ons, delayed course clamping that is being done in a normothermic environment. So all these things are so important. It's a multi-package thing that will be part of kind of why these patients develop or not severe hemorrhages. And so one of the things is when you're looking solely at giving medication to try to address the duct, thinking that this may help, well, one thing we know is that if you give prophylaxis of indomethacin, you decrease your rate of severe IVH. But what is indomethacin doing? Is it really acting through the duct? Probably not. Why? Because NSAIDs are one of the most potent vasoconstrictors that we know for preemies and babies. And it doesn't constrict necessarily just the duct. It constricts everywhere. It constricts the pulmonary vasculature. It constricts the systemic vasculature. It constricts the cerebral vasculature. And these patients already have like probably some degree of autoregulation immaturity. And so you're really uniformly vasoconstricting everywhere. And so what happens when you give these indomethacin or these NSAIDs is that you're profoundly changing the cerebral flow or the gut flow or the renal flow. And that's why we see these patients with AKI. That's why we see like rise in creat. That's why we see sometimes perforations, because you induce spasm of vessels, especially in an area like mucosa that are super dependent on blood flow to stay well perfused, and you induce perforations and you induce AKI, and probably you induce vasoconstriction in the brain. And we know from studies, like these are two studies, for example, where they gave indomethacin and they followed the patient by cerebral oxygenation, and they found that there was a sustained drop in NIRS values in these babies hours after giving the NSAID. Like not just like a few minutes, but hours. And I think, let me just see if I can share a slide here. Yeah, that's the slide that's hidden. And all the infants, cerebral blood flow, oxygen delivery, blood volume, and the reactivity of blood volume to changes in arterial carbon dioxide tension fell sharply after endo. And these fall in cerebral oxygen delivery and the disruption in cerebral vascular control might compromise cellular oxygen availability, particularly in regions of the brain where the arterial supply are precarious. That's 1990. That's not like last year. We know that for like 30 years. Dr. Arvind Siegel, actually from Monash, did a huge literature contribution, and he actually shown that by giving NSAIDs, you even decrease coronary flow. Like you get probably myocardial ischemia secondary to that. And that he's shown by echo. Super interesting. So then the next question. Do you see my PowerPoint in slideshow, or do you see my PowerPoint in, okay, perfect. So what about neck? Well, systemic steel and diastole, this is a concern, can it cause intestinal ischemia? But we know that many babies, even if they're immature, they do keep some degree of autoregulation. And so even if you have drop in your diastole, your body is going to try to react by increasing systolic upstroke. And that's why the LVO is increasing to some degree, and you get sharper like systolic peaks. And what, many may wonder, like, is that sufficient? The problem we have with NSAIDs and other drugs is that, again, you're vasoconstricting. And if you're not vasoconstricting, could there be direct toxicity of some of the inhibition of PGE, for example, or some of the other byproducts that you're trying to inhibit, right? These markers are pro-vasodilator markers. So even if you're giving, for example, Tylenol or are you causing some concern about your intestinal integrity by giving these medication? Also, if you're using the oral meds, well, we know these medications are extremely osmolar, especially Tylenol, because you're giving like the cherry version, especially in North America or Canada, because that's the one we have. Like it's the one you can buy at the market, like the syrup that's super osmolar. And then there's a question about mucosal integrity of inhibiting these pathways. That's a huge concern. BPD, well, BPD is a big bag of things. BPD is lung disease. We know that lung disease comes in different shapes and forms. A baby at 36 weeks on bubble CPAP at 21% who goes home in room air breastfeeding is not exactly the same as the patient who's still intubated and gets a tracheostomy and goes home at 56 weeks and needs G-tube and is still on oxygen. Like these are not the same patients. We know that. And some of them have airway disease, and some of them have lung disease, parenchymal lung disease, and some of them have patchy disease and vascular. So they're just very difficult to categorize in one place. But we know that these lungs, as they're growing, are getting injured by factors like that are happening sometimes even prenatally: choreo, growth restriction, placental insufficiency. Postnatal, whether you got inflammatory reactions or infections or neck, or you got airway disease because you got intubated 5 times. If you had PIE, if you were not able to be extubated despite multiple other NIMV modes. So there's so many contributors to this lung disease that to pinpoint like just the PDA being part of that becomes very difficult to kind of swallow. There's just so many things happening. So what's the contributor of the PDA in these patients? Could the increased QPQS, the pulmonary edema, the pulmonary inflammation leads to BPD? Or is it just that, you have mature lungs, you have inflamed lungs because these lungs are being exposed to oxygen when they're not supposed to be exposed to oxygen. They're exposed to distending pressure when they're not supposed to be exposed to distending pressure. They're exposed to atelectasis. They're exposed to bacteria and flora colonization. And this is the setup of babies that have just very immature ways to address the inflammation, the growth, and all these things. They have immature mechanisms to respond to that. And so, if you have immature lungs and these lungs are inflamed, obviously inflammation can participate in maintaining the duct patent, right? Because you're producing more prostaglandin, you're producing more inflammatory markers. And that's where you start wondering, well, what is the whole role of postnatal steroid in these patients? And we know from studies like example, Premilock, they were able to drop their BPD rates, probably because you're modulating inflammation. Oh, and oops, they saw there was less PDA treatments. Well, of course, because you don't need to give a PDA treatment if your lungs are doing better, right? So what about pulmonary hypertension? Well, these drugs, they're specifically toxic for vessels. They vasoconstrict. They reduced the formation and arborization of pulmonary vessels. They changed the migration profile of endothelial cells, and they reduce cell proliferation. Why? Because probably there's a direct effect, but there's probably also an ischemic effect, right? You're exposing a potent vasoconstrictor for days and days and days. You decrease the flow to a structure. If you decrease the flow to a structure, you stop growing. We know that with hypoplastic left heart and tricuspid atresia and all these things, you have less flow, you're going to reduce the arborization for sure. But just the vasoconstrictive effect and probably the primary effect on the vasculature creates toxicity. So we know treatment of newborn rat pups with ibuprofen reduced dramatically their pulmonary vessel density and developing lungs. And so there's probably a primary impact of NSAIDs on the pulmonary vasculature. And when you look at papers that are associating the PDA to pulmonary hypertension, first of all, they're obviously, confounded by the fact that the babies who have more pulmonary hypertension are the ones who are tinier babies and who are the ones who have more PDA. So of course, if I take something like being exposed to TPN or being exposed to a PICC line or being exposed to a gavage tube, and I try to associate that with complication of prematurity, I'm going to find an association, 100%. Because if you're born at 23 weeks, more chance you're going to get longer TPN, more chance you're going to get longer gavage tube, more chance you're going to get longer PICC lines days, just because you're more immature. Is it the PICC line or the TPN or all these things that are causing BPD or causing pulmonary hypertension? Probably not. Maybe it's a reflector of it. But the same thing you can ask yourself, PDAs are going to be more frequent in the tinier babies that are more immature. That's number one. That's for sure. It's not going to change. Now, all these studies, they're not centers where they don't give NSAIDs. They're centers where they give NSAIDs. It's not like suddenly they're taking a population that what is exposed to no PDA treatments or strategies to accelerate the duct closure. These are centers that are actually actively pursuing these ducts, and they're giving to some degree treatments. Although some of these centers like this one is a bit more conservative than your general centers, they're still providing treatment. And when you look at the data, the group who developed PH, actually double of them got PDA treatment. So then the conclusion is like, oh, there's an association between PDA and pulmonary hypertension, but these PDAs were actually being exposed to whatever, strategies are being, advocated for the closure. So that becomes very confusing. Is it really the duct, or it's actually because you keep on giving these medications that are toxic for the lungs that you develop more pulmonary hypertension, right? If you keep on giving NSAIDs and NSAIDs are bad for your pulmonary vasculature, well, of course, you're going to associate the PDA to pulmonary hypertension because maybe the NSAID is actually the culprit. Maybe it's that's causing damage to your pulmonary vasculature.
When we looked at our population and we compared it to another population, we actually found that our pH rates were similar between the two sites, even if our site doesn't give any kind of NSAIDs. And actually, we were slightly a bit lower, although it was not statistically significant. But in any case, it's a rare entity, and we don't see that much pulmonary hypertension, as you saw. And many of these patients that develop pulmonary hypertension, they never had a PDA. So we have one patient on the ward right now that, has some degree of pulmonary hypertension. That patient on first echo day 1 had like no duct. It was a growth restricted patient. So sometimes it's very difficult to make these kind of association. What we see here is that even in population in which we're not giving these NSAIDs and we don't see high rates of pulmonary hypertension. Probably because we don't see that much BPD, and it's BPD that's often the culprit in pulmonary hypertension. So if you have lung disease, then you have pulmonary vascular disease. So this brings me to sorry about that. This brings me to the questions like, what are the interventions we have available to achieve our goals? And so what are the goals? Is the goal just to close the PDA? That could be the goal. But really the goal is to actually improve outcomes, right? And so the question we have to ask ourselves, are these interventions with no adverse effects or adverse effects that are actually trivial compared to the proven benefits? And so once you do close or you restrict the shunt, are you seeing these adverse outcomes that you previously targeted? Are they either not happening, or are they significantly less severe if they do happen? Can we prove it? And is this at the expense of really trivial effects or side effects? So are you able to actually improve your outcomes or diminish the amount of bad outcome severity? And is whatever you're using in terms of intervention not creating more damage than it's supposed to do? So this is a really nice systematic review that was done by Shuvik Mitra, actually, as one of the co-authors. And they write, in 68 randomized controlled trial of 4,800 patients, 14 different variation of NSAIDs, Tylenol were used as treatment modalities. The overall PDA closure rate was 67%. So the question is always like, well, first of all, would this 67% close anyways? And what about all these others? Are these really the ones in which we would have hoped to achieve closure? Are these the ones that actually really are expected to benefit the most? So you have a therapy that is a bit of a, flip a coin. Half of them maybe is going to close or not. And maybe you're going to expose half of that population to a treatment strategy that actually is causing a lot of side effects and not gaining any kind of benefit out of it. So that's always the concern, right? That we have in the background of our mind. And then you're going to start exposing and exposing and exposing. Are you creating more damage with this approach? And don't forget that a lot of the trials that we've done, they reflect the reality of how we practice. When you look at the population of patients in these trials, you always will have to wonder, is it generalizable to what I do in my unit? Is it generalizable to like kind of the population I see? And most of them, they are. This is how we practice. So why would the conclusion be different in my population? That's something you always have to wonder. So even if the PDA is part of the problem, it seems that whatever strategy we have today to try to close them or restrict the flow is really not that very efficient. First of all, it doesn't close all of them. There's a lot of toxicity. We talk about cerebral vasoconstriction, renal vasoconstriction, intestinal vasoconstriction, SIP, platelet dysfunction, bleeding. And then long term, what does it do to the long term? Are these patients having more hypertension because of that? We're hearing more and more centers that are actually treating the duct, and they talk about this phenotype of very significant systemic hypertension, something that many centers who don't use NSAIDs are not really describing. So are you creating more renal injury, AKI, hypertension because of that, long-term renal issues? Are you having anti-angiogenic effects on your brain, on your gut, on your kidney? We don't really know long-term how much this is really affecting our babies. We think it's temporary, but who knows, right? This is a huge meta-analysis that was done by Bill Bennett and Shazia Bombal. They've looked at all the trials. They looked at the age of treatment. They looked at tinier babies versus bigger babies. And they found that actually there was only thing that you were achieving is that you were reducing ductal patency. But all these other outcomes, no difference with NSAIDs. One of the trial that was very interesting is the one from Australia where they did an echo in the first 24 hours of life. They were supposed to recruit like something like 400 patients. They were able to recruit about, 90 patients. And the reason is that indomethacin got part of it discontinued during the time of the RCT. So they had to close prematurely, and they were also not able to recruit to the rate that they would have wished to recruit, from what I believe. And a lot of people bring to me, oh, pulmonary hemorrhages, pulmonary hemorrhages, pulmonary hemorrhages. But look at the results on pulmonary hemorrhages. 23%, 9%, all pulmonary hemorrhage, no difference because it was not powered for that. Pulmonary hemorrhages during the first 72 hours, there was an effect. 20% of pulmonary hemorrhages. I can tell you, I have not seen any studies showing 20% of pulmonary hemorrhages in any units that are having conservative or non-conservative approaches. Like in our unit, it's less than 8%. I think we published it recently. So there's a concern about what is this? Why do you have so many in your placebo group? Is it because they're all intubated, getting a lot of surfactant? That was one of the questions of the study. But globally, not significant. All the pulmonary hemorrhages, there was no difference. And when you look at pulmonary hemorrhages, well, is it that the PDA shunting caused the pulmonary hemorrhage? Or is it that just these babies have very fragile vasculature? So the moment you change the hemodynamic by giving things like intubation and oxygen and surfactant and dropping their CO2, well, what are you going to do? You're going to rush blood flow in this pulmonary vascular bed, and these vessels are going to burst. And if they burst, what's going to happen? You're going to create a lot of pulmonary hemorrhage. And to manage these patients, what do? You crank up your mean airway pressure to try to tamponade. And when you increase your mean airway pressure, what happens to the central venous pressure? It increases. So meanwhile, you have hemodynamic instability, hypotension, and you're increasing your SVC pressure because of the intrathoracic pressure that increases. And so you're blocking the venous drainage in the brain. So what's going to happen to these little fragile capillaries in the brain? They're going to burst because you have a post-capillary hypertension. You're not able to drain your brain, right? So that's a big issue. So drastic drop in PVR leading to rush of blood flow following surfactant, irrespective of PDA presence. So we have patients with no PDA and they develop pulmonary hemorrhages just because of these very rapid shifts in PVR SVR ratio. Loss of integrity of the immature blood vessels leading to bleeding in context of high left atrial pressure, poor LV compliance. So we know our preemies have a tendency to have, not the same LV compliance as patients that are born at term, for example. So they may have less compliant LVs. And when you go postnatally into a setup where PVR drops, it's just the LA and the LV is not able to accommodate that because it was not supposed to see high venous return from the pulmonary vascular bed for another 20 weeks. So suddenly you have to accommodate high pulmonary venous return, and this LA and LV compliance are just not made for that. And then aggressive surfactant practices without adequate PEEP support, caution about giving a lot of Lisa and Mist in these very, very tiny babies because of this. And there's been countless of other studies, many RCTs that were done in France and Ireland, Europe, the PDA tolerate study, the study from Dr. Rosé, Trocapi. A lot of money is made and pushed in trying to show a difference, and there's still no difference. And we keep on putting money and thousands of babies being randomized and studied and blah, blah, blah. So at some point, we're going to ask ourselves the question, are we studying the right approach? Like, is it the right way of doing things, right? And when you have trials in which the biases are getting out and the confounders that you're measuring and not measuring are getting out and they're being balanced, and you don't see differences, you wonder, well, am I going to see a difference in my own population and my own approach, right? And the problem with observational study, and I do observational studies, is that there's a lot of other confounders that you cannot account for. The nursing experience, whether or not, the ventilators that you're using, your approach to surfactant, the types of babies, whether or not they got steroids or not steroids prenatally, the inborns, the outborns, whether or not the family decided to reboot the care or not. Like all these things get mixed into the observational study. And in trials, that's the goal, is that you're able to equalize them in a very random fashion. So all these things are being balanced in the groups, and you avoid some of these confounders. And what became a bit clear is in the recent trials. So this is a study about expectant management or early IBU and PDA. And this particular study, which was the Benedictus trial done in Europe, they had almost no patient in the expectant management group that went off-label and got NSAIDs. So this group really was free of getting NSAIDs. And they were tiny babies. They were like 24, 23, 25 weekers in this study, mostly 24, 25 weekers. And what we see is that the group exposed to ibuprofen, 51% of them got moderate to severe BPD. Now, sometimes you're like, well, if you survive, you're going to get more BPD, right? A great way to prevent BPD is to die, because BPD is something that happens later, all right? It's not that they survived more, 18% mortality. So it's not because they survived more that they got more BPD. So they died, you could argue, to the same level, 14, 18%, even a bit more here, almost the double amount of BPD. And you remember we said NSAIDs, there's a concern that it could be toxic for your lungs and your vessels, vasoconstricting and primarily injuring pulmonary vasculature. And then you see people are telling you, oh, well, it's probably because, the way we selected these babies is not the right way. Well, actually, this was randomized. So these patients were attributed in a random fashion. And the criteria they use are actually the criteria that the majority of units across the world are using to select patients to give NSAIDs. And I don't believe that people across the world are not smart people. People are very smart in the way they assess these patients and choose who they're going to be exposing to or not. And what you can see here is that these majority of patient, diameter is not a great way for sure, but I think having a 2.1 diameter as the majority of these patients, because this is the median or above, is a pretty significant shunt. It's not like trivial. Fine. We don't want to, argue about the diameter. We're going to look, of course, at long-term outcome because it's very important. This was recently shown at one of the conferences. There's basically no differences in terms of survival without neurodevelopmental impairments at 24 months based on whether you treat early or you do expectant management. They have kind of the same. So you have less BPD, less lung disease, probably, because of that, less burden of disease. And whatever we can measure in terms of NDI, they seem to be doing pretty much the same, 49%, 49%. So that's reassuring regarding expectant management. This was not powered to show superiority. This was a non-superior study, non-inferior study. So it was done to show that one approach was not inferior to the other. So they would have not been able to prove that it's superior in terms of long-term outcomes for sure, because it was not even designed to show superiority at the early level, but it did show a signal that was of concern. So I think that treating every PDA early is not the answer to this unsolved question. It's definitely not, because we're exposing patients to drugs that are potentially having long-lasting side effects that we still don't understand fully, and we're not able to show that we're actually improving their care and outcomes. And so when you're looking at neurodevelopment, there's been other study. This one was an RCT that basically shown the same thing. They looked at echo in the first 6 to 12 hours, and they looked at survival without CP versus placebo, no difference. And recently, we just looked at comparing our population to another population at another center where they use NSAIDs and treatments, and we found that they had the same neurodevelopmental outcomes. So another big RCT that you guys should know is the baby Oscar study out of the UK group from Dr. Gupta. And what did this study do is that instead of having expected management, they actually had placebo. So these were really patients, like they did echo, they randomized them, and either you received ibuprofen placebo. So there was no way for you to know which patients was which. Now, one of the things is that there was permission to use off-label. And so a big group of population from the ibuprofen and the placebo got eventually NSAIDs because people did not know if they got NSAIDs before or not. And there were, there's a bias towards potentially trying to close these ducts when you're being told by your echo that there's a duct there. So there was still a good proportion of these patients being exposed to NSAIDs. Now, despite that, we saw that the primary outcome, which is death or moderate to severe BPD, did not reach statistical significance. So you would have hoped that the group ibuprofen would improve if you think that ibuprofen is able to close the duct, which is able to improve the outcomes of the lungs. But we know ibuprofen is, first of all, not closing the duct in many of them. And second of all, it has the toxicity that it has. So this drug and this strategy doesn't seem to be working well because we get the same, and probably we're getting the side effects of the ibuprofen, which is the issue and the concern. When we look at BPD, we even get to see that probably there's a signal to worse BPD. And if you look at the adjusted odds ratio, which are all crossing 1, telling us that are not significant, so either evidence of benefit or evidence of harm, they're all trending towards more an evidence of harm. 1.09, 1.32, 1.09, 1.30. Nothing is less than 1, definitely. There's no signal showing that remotely it improves any of these outcomes. And so then the argument, oh, is 1.5 millimeter not a good criteria? This study didn't just use 1.5. You actually had to have an unrestricted transductal pulsatile left to right shunt. That was their criteria in order, and they're giving actually what's their definition of a pulsatile unrestricted shunt, which is one of the only study that actually provides a clear definition of what they use for unrestricted. So that's a good reference to know if ever you're trying to reference a particular definition for unrestricted flow. So this was not just about having a 1.5 millimeter. And actually, when you look at the Benedictus in this study, the majority of patients had diameters above 2 or even above 2.5 millimeter in this cohort of patients. Now, you probably know this paper from Gabriela de Carvalho Nunez, who was a fellow previous years ago here. And she looked at our entire cohort from 2015, 2016, 2017, 2018, 2019. And she's shown that the majority of our population of patient, which was not exposed to NSAIDs or Tylenol, well, 90% ends up being closed eventually, whether you're less than 26 weeks or more than 26 weeks. And that's a pretty good amount of patients being born at 23, 24, 25 weeks, and they still close eventually. And when you look at BPD, so death or BPD, you can see that death and BPD, they're kind of dropping along all these years when you look at the preemies, right? Now, less than 26 weeks, you see death or BPD, because these only contains the patient that are survived, right? So we don't include mortality. So you have a bit of mortality. So that's why it's 84 versus 116. But you see that death dropped significantly with the years. And you can see that BPD also has a trend in dropping, like 85% to 59% in less than 26 weeks. And when you look at BPD less than 29 weeks, only 28%. Very tiny rate of BPD. Very tiny. And that's oxygen arrest support at 36 weeks. Just to show you that in our population exposed to no NSAIDs and Tylenol, our BPD rates are extremely low and our mortality rates are extremely low. And when you're looking at those who have BPD, 0 on mechanical ventilation at 36 weeks. It's extremely rare we see in our population these patients still being stuck on ventilator at 36 weeks. If we get any, it's often because they have an airway disease for some reason, and it's often not our population, it's often babies who are referred from other centers. Many on low flow, a few on CPAP, and that's really the tiniest babies, the most immature ones. This paper from the group of Dr. Santana, Gabriela, and I was one of the co-authors, You know that we also introduced, so in 2013, we stopped giving NSAIDs because we felt they were very toxic and they were not achieving what they were supposed to achieve. And then in 2014, we adopted bubble CPAP as a primary mode of ventilation in all our babies. And this is your rate of death for BPD. And it's dramatic drop through the years. So, people are thinking, oh, well, you stop doing NSAIDs, you don't treat the duct, your BPD will increase. That's not what we see. That's not what we see, at least in our setting. But again, because it's observational, there's so many other things happening through time. BP, the bubble CPAP approach, the way we give surfactant, the way we train our nurses, the move to new centers, all these things. So it's not just the fact that we stopped using NSAIDs, but at least what's reassuring is to see that despite the fact that we stopped using NSAIDs, we didn't see that increase in BPD in our population of patients. So this is death or severe BPD that dropped through the years, and this is intubation that dropped through the years in the first week of life. And when you look at severe BPD, death or severe BPD, very low amounts, 8 on 124 patients in 2020. And again, this effective drop through time. So what about Tylenol? More and more of the literature is trying to, find a new cure or a new way that would be efficient. When you look at the PDA Tolerate study, which was an RCT done in mostly the Bay Area, but a few centers in the US, they found that with primary Tylenol approach, only 27% of these patients actually closed. Even when you gave like 4 or 5 days of Tylenol in a row, many of these patients were not actually closing. Probably because they're too immature to close and probably because it's not that efficient. So again, you get into the world of exposing your baby to Tylenol, which creates the toxicity of the exposure in all these babies that are not achieving the effect, plus in those in which you're achieving the effect, but at least you closed it, but really not that efficient. And Clyde Wright, who is based out of Colorado, if I'm not wrong, actually brought out a review article saying that, Tylenol gets metabolized in adults and pediatric through the liver. And when you saturate the liver processes by giving tons of Tylenol, we know that it gets very toxic to the liver. You can go into severe hepatic failure, right? That's why we go and we give them N-acetylcysteine as a way to counteract the effect of Tylenol. In some of these patients who took tons of Tylenol, it got Tylenol intoxication because you can go in complete fluid liver failure. Now, fetuses and babies, they don't process Tylenol the same way. And it tells you here, hepatocyte cytochrome P2E1 expression is very low in the fetal and neonatal period within the liver. In the lung, in the fetal and neonatal period, actually support that the lung expresses high level of this enzyme. And so when you saturate these enzymes by give them too much paracetamol or Tylenol, you're actually increasing the toxicity level at the level of the lungs. So this review article raises awareness about, guys, we don't really know what we're doing with this Tylenol. Are we creating more byproduct of toxic glutathione anti-inflammatory effect that you're supposed to have in your lungs? Suddenly you're suppressing that and you're creating much more oxidative stress when you saturate these mechanisms because they're all situated in the lungs. And actually in rat and animal models, if you give too much Tylenol to these patients, there's risk that you see like BPD phenomenon and BPD phenotypes. And there's even been like actual papers and case reports of, because of the high osmolality of these forms, you can get spontaneous intestinal perforation in some of these patients, but these are just observations. So then you get to like more definitive way of closing. Like at least you know it's closed. So how do we know it's closed right now? What are the techniques? Is that you can either go by surgery and then ligate, you know it's closed, or ligate it as much as possible, or you put a little catheter and you close it. Now it sounds great, but yeah, it provides certain closure, but when are you going to do that? Which time point? I bring you back to the timing. We said IVH in the first 2 days. When are you going to do that? If you're going to do that at 3 weeks, you're not going to change anything to your neck and your IVH and all these things if you think the PDA is the culprit. So then are you going to do that at day 2 of life in a 23-weeker when they're still going through their transition? Ligation is a big surgery. You can get post-ligation syndrome when it's been a while that the PDA is open. You can create inflammatory surge. You can compress your lungs. You can cause damage to the lungs, damage to nerves. You can get vocal cord paresis, diaphragmatic dysfunction. So this definitely comes with a lot of morbidity. It's an invasive procedure. What about cath-based? It looks like all like very trivial to do a cath. Well, you need expertise. You can cause limb injury. So if you go through an artery in the tiny leg and you break the vessel there, or hematomas or ischemia to your limb. So I've seen babies lost their leg after a cath that was done in less than 1,000 grammars because they're high risk procedures, right? If you go to the cath lab because you have no choice because you have a TGA at 900 gram, there's a risk you can lose your limb. And that's something we tell families, like, these are procedures we have no choice to do, but they come with risks. You can have atrial injury, you can rupture your atrium, you can damage mitral valve, tricuspid valve, depending on your approach. You're exposed to anesthesia. All these medications have potential risk. You can bleed, you can infect, you can get postoperative complication, clots. Then the clot, you have to anticoagulate, then they bleed because of that. You can have the device that cause problem. You can obstruct on your aortic end or pulmonary end. You can embolize your device. So there's many complications that could happen. And the problem is, like, when you're doing this, is it really improving your outcomes? Right now, we don't have data that shows you're improving outcomes. So my personal bias is that if you're going to subject tiny babies that are fragile to these intervention, they should be in the context of studies, investigation. You should tell parents, we don't know. So it's fine if you're doing a study, like right now there's the pivotal trial, but to just do it to do it, you have to be very careful and very honest and transparent with the families. What about other modalities? Postnatal steroids, supportive or conservative management. What do we mean by that? Well, we know already there's been a few reports, case reports, and here it's another case reports where there seems to be potentially ineffective steroids on the ductus where it seems to actually potentially help the constriction of the ductus. This study from, again, Dr. Siegel from Australia, they found that in 30 patients, average gestational age 24, 25 weeks, and small birth weight, they gave DEXA at around 20 days of life, plus or minus 9 days standard deviation. And these patients, they noted that in 20 infants, the ductal diameter actually decreased significantly. And they actually had complete closure in about 35% of them. So is it that the DEXA is actually acting on the duct diameter and at the same time reducing inflammation because there's less inflammatory markers? This duct has a tendency to constrict because we know that inflammation keeps the duct open. Or is it just time? Or is it a component of both? We don't know. Locally, as you know, we're doing the SPEC study, and hopefully Phoenix will be able to tell us this in a few years. And actually, the CPS recommends that if you have an infant that remains ventilated after the first week of life with increased oxygen requirements and worsening lung disease, the benefits of dexamethasone therapy appear to outweigh the potential adverse effects. And in these circumstances, low dose DEXA should be considered. Now, we know that whatever was studied in the past, like DART, it's a single regimen of a particular amount of dexamethasone. And probably in some babies, that's sufficient to kind of get out of the mechanical ventilation and drop a bit your inflammatory storm. But there are babies that have significant lung inflammation in which this is just not sufficient, and probably higher dose of dexamethasone at that point are necessary. And I just want to share one protocol that you've heard probably, New York, Prematurity, randomized controlled comparing. So this study was actually a group in New York at Syracuse, actually, where they did a prospective randomized controlled trial in 59 infants less than 27 weeks. And they compared, so they recruited these patients with extremely significant lung disease, so high MAP, high oxygen needs. And they started as per day 10 of life, so about, 1.5 week of life. They started either dexamethasone at high dose over 42 days or dexamethasone at a bit of a lower dose for 9 days. And this is already higher than the DART. like the DART is, 1 point something milligram per kilo. This is, if you do 0.5, it's like something like 4 milligram per, 2 milligram per kilo or something. It's like the double amount of dexamethasone than the DART in terms of cumulative dose. And they looked at their long-term outcomes, intact survival with IQ more than 70, function in school, blah, 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 blah. So they actually followed these patients until a much later age. Because to do an IQ, you cannot do this at like 24 months. You have to wait quite a bit. They have to wait to school age, and that's what they did. And what they found is that the 42-day tapering course of Dexa in these very, very high-risk babies, so we're talking about 25-weeker babies, intubated, ventilated, high oxygen needs. When you compare that, yeah, there you go. The 9-day group was 4 milligram per kilo, and the 42-day group was 7.56 milligram per kilo. And just to give you a sense, DART is 1.3, if I remember well.
Could you share the screen? I mean, it's like the New York paper.
Wait, you're not seeing my screen? Here. Did you see that?
Just saw that.
Okay, so a total cumulative dose of DART is 0.89 milligram per kilo. And then here, the Syracuse study, so as I said, 59 infants were recruited from 2006 to 2010. One group, so high immunopressure, high oxygen needs at day 10 to 20 of life. One group got 42 days, which is the equivalent of 7.6 milligram per kilo. It's a very high dose. I don't recall any babies that we exposed to that degree of dexamethasone. And the other group was 4 milligram per kilo. So just to remind you that dexamethasone at the DART level is 0.89, like very tiny amount, right? And so 2 doses of DART would be, double. So we had patients with significant lung disease that needed like 1.5 or 2 milligram per kilo. I've never seen patients that required up to 7.56. But what they found is that at school age, intact survival at school age was significantly increased in the 42-day group compared to the 9-day group. So these patients survived more without brain disease because probably you're addressing the inflammation storm that's happening and that's causing issues with the brain, hypoxia in the brain, inflammation in the brain, and all these things that are causing white matter injury. Now, you don't want to start dexamethasone on all these patients, obviously, but the patient that is at high risk of lung disease and inflammation, because lung disease is a reflection of the inflammatory burden they have in their body, that's the patient you probably want to consider giving steroids. So if I go back to my presentation, you're seeing my presentation?
Yes.
That's why the CPS says that if you're at that point, ventilated at 1 week of life, and you're still on increasing oxygen requirements and it's worsening lung disease, this is a reflection that there's like a lot of inflammation. And at this point, DEXA should probably be considered. Forget about your duct at that point. Like the lung is like so damaged, there's so much inflammation, like you need to address this. And this is a very nice systematic review by Lex Doyle from Australia. Amazing, amazing researcher, where he looked at dexamethasone, he looked at hydrochloride. Hydrochloride doesn't have great penetration in the lung. It's a great medication for support of the cardiovascular system, not great for like pulmonary penetration and pulmonary inflammatory modulation. What he's shown is that probably in babies in the early life when the risk of BPD is not that high, giving low dose hydrocortisone might be something that seemed to have a beneficial effect, although it crosses 0. I don't know if you see here, crosses 0. But as you're getting more risk of BPD, now again, BPD being a surrogate for the inflammatory disease and burden they have, it's not necessarily the BPD itself that you're concerned about, it's just a surrogate of it. You change nothing about these patients. It's clearly crossing 0. But when you look at DEXA, you have here the BPD and the control group. So these are RCTs in which they took a control group and they took an interventional group. The control either got placebo or nothing, and the steroid group was randomized to dexamethasone. And if the control group had very high risk of BPD, which means high inflammation, you didn't do anything in terms of trying to temporize their inflammation by giving them steroids, clearly beneficial. If your control group had almost no BPD, so it tells you if a baby is at very low risk of developing BPD. 28 weeker on CPAP plus 5, 21% at day 7 of life, day 14 of life, day 21 of life. It's not going to develop BPD. This kid doesn't have much inflammation. Really, giving steroids is not a good idea. But the 23 weeker at 14 days of life, who's a 90% of oxygen, mean pressure of 15 on high frequency jet, probably giving dexamethasone because the risk is so high that this patient would develop eventually pulmonary inflammatory disease. At this point, DEXA seems to be improving them. And so the question is, is DEXA addressing the inflammation? Is it closing also the duct? Is it helping the overall burden of inflammation in these patients and eventually their lung disease? Now, the question can come like, what happens to these patients if you're not giving them medication and you're not giving them ligation and you're not giving them NSAIDs and Tylenol and cath? So what happens to these patients? Well, we know that fetuses, as they grow, develop the mechanism to actually close their duct. So why would it not be true for preemies? And you can see here that it's true that 23, 24 weekers, 25 to 26 weekers, and 27 to 28 weekers, well, the more mature close earlier. It makes sense. They get to 36 weeks earlier. They get closer to the maturity earlier. A 23 weeker will take more time for that. So it's normal that all this is shifted. But if you look, they eventually spontaneously close. They eventually will close this duct. If you leave them alone, they will eventually close these ducts. So of course, being born at 23, 24 weeker, you'll take more time to close it, but you'll still close it. And that's also true in a cohort in Europe, where you see these are the less than 26 weeks. This is 26 to 27 weeks. This is 28 to 29. This is more than 30. And it takes more time, but they close it. And that's what we see in our patient population. So if you leave them alone and you don't try to do stuff, they'll eventually, most of them close it. In our population of patients, I believe we had like, since 2013, something like 17 cath closure in preemies, something like that. I would have to go back in the data, but like it's extremely a rare occurrence that we have to do that. Of course, if you're syndromic and you're right, or you're at term and you still have large shunt, that the risk, the likelihood you're going to close it spontaneously is much more unlikely. And at this point, even locally, we'll have a tendency to do cath closure. Sorry. So I think because of all of these reasons I've outlined, that's why we see that the treatment rates are dramatically dropping. So this is pharmacological, invasive, combined, and the total. So you can see that the total is really dropping across the US and North America because people are realizing that whatever approach or whatever you call the treatment is coming with so many counterparts and so many issues, and it's actually not achieving the goals of what we wanted to achieve. Even if the PDA was a disease in early life, if the treatment or whatever you have doesn't address it and has side effect, why are you going to use that, right? So let's say I would tell you like, oh, an infection. Unless you have the antibiotic that's appropriate to it, why would I give another antibiotic that doesn't work for that infection? It just doesn't work, right? So you have to wonder, are we using the right approach? So my conclusion, and you can see all my biases, is that the current strategies to address the ductus, NSAIDs, paracetamol, ligation, cat closure, although extensively studied, they have not been shown to improve these outcomes, and that's the expense of significant toxicity. So this approach is not the right one. Maybe there's other approach that's going to be showing improvements. Maybe the PDA has a contributor, but whatever we have right now, like NSAIDs, is not helping this. It's not really improving our outcomes. And we've put a lot of money. So it's funny because it's like almost we don't want to believe all these studies that are being done. And we keep on doing studies and studies until we find the study that's going to give us, oh, now I have the answer that I wanted. But that's not how science works. We don't do studies to prove something that we want to prove. We do studies to show if an approach makes sense. And the data speaks. So all these trials have been done. More than 5,000 now patients have been recruited in these trials. This is like millions and millions of dollars. And at this point, it's almost unethical to actually give NSAIDs for the purpose of closure of a duct without a parental consent because you have all of these studies and you know they create side effects. And it's almost unethical to do more studies on particularly this medication, knowing the amount of data that is so overwhelming that is showing that it's causing harm and it's not improving the outcomes. So conservative management, non-invasive rest support with bubble CPAP, standardized approach towards premature care, and cautious use of dexamethasone in ventilated infants seem to yield the best results right now. That's what we have until we're able to have new strategies that can further improve all these causal pathways. And I want to remind you that sometimes less is often better for these babies. So if you scan this QR code, you're going to have a whole big paragraph on what's my thoughts, but I think I expressed my thoughts today quite clearly. And that's it. These were my thoughts on this.